past, present, and future. Please give a big round of applause for Dr. Lee.
Thank you, Professor Yang, for the kind introduction. First of all, it's my great honor to be here today for prestigious Jisan lecture. My connection with Korean Society of Ultrasound in Medicine is very special because when I was a first grade resident, I delivered my first academic presentation in KSUM back in 1986. And also, my first scientific papers was published in Official Journal of KSUM in 1986. After learning radiofrequency ablation in the United States, I introduced radiofrequency ablation to Korea. Over 25 years, ultrasound-guided liver ablation has been the center of my clinical practice and academic research. So that's why this opportunity is very special to me. Actually, I'm very sorry I got wrong information from Google, the misspelled Professor Jisan. Over the next 25 minutes, I'd like to walk with you through the past, present, and future of ultrasound-guided liver ablation. Let us start about the past. According to the literature, liver aspiration biopsy was developed in 1958, and in the 1970s, ultrasound-guided biopsy began to gain attraction. By the 1980s, many local ablation therapy, including ethanol injection, microwave, and radiofrequency ablation, were actively developed and widely adopted. From 1980s up to now, there are so many weapons in our hand for treating liver tumor. Turning to the history in Korea on liver ablation, the first case of percutaneous liver RFA was performed April 28 in 1999 in Samsung Medical Center. The following day, second case was performed by myself in Hanyang University Hospital. This is my first case RFA in Korea. Unfortunately, first complication case, which I cannot forget. In the same year, we established Korean Society of Image-Guided Tumor Ablation. In 2014, we launched Asian Society. We held the first meeting in Taipei, Taiwan. After then, we successfully hosted meeting in Japan, Korea, China, India, and so on. So I believe Asia is the birthplace of local regional treatment. So we should be proud of it. Our past was innovative. Moving on to the present, what is the current status of liver ablation? Thanks to the many contributions of our society, we made many evidence for guideline. According to the review paper by Dr. Liang Ping, almost half of the papers were published from Asian country, the ACTA founding country. As we all know, ablation is already approved as a curative treatment option for early stage HCC in most treatment guidelines. I would say ablation is sound positioning in treatment guidelines. Ablation is one of the best player for early HCC who knows its pros and cons. And also recent collision study also proved ablation can be a good standard for hepatic metastasis, comparable to surgical resection. Microwave is the main ablation option worldwide due to the better tumor control in a short time. However, we need more evidence for real survival benefit compared to radiofrequency ablation at the moment. In Korea, also still radiofrequency ablation is the predominant energy source for treating HCC because most clinical studies fail to prove the real survival benefit of microwave ablation over radiofrequency ablation. Which energy is best? This is actually a long-standing question in every conference for 30 years, but we don't have a clear answer. So it's time to move from which one is the best to how to use it in a right way. Regarding technical standardization, recently Korean Society of Liver Association published a document on recommendation of liver ablation, including patient selection, pre-treatment imaging studies, preparation, performing, and follow-up strategies. You can find this journal in details. And also, Asian Society of Tumor Ablation recently published our guideline, including indication and planning and diagnosis, as well as techniques. You can find the details in these recent articles. Let me introduce my recent recipe for local ablation. As we all know, tumor conspicuity and the safety and tumor size is the really critical factor for successful ablation. But recently I recognized tumor exit is also very important to achieve the best result. So if all factors are satisfied, I do the single microwave ablation through the central core of tumor. If any factor is no, at the time I consider multiple RF electrode. Let me show the first case, a small, conspicuous, with exit in safe location. About 1.2 centimeter, not subcapsular, that means that there is an exit in the tumor. Lesion conspicuity is quite good. We don't need CUS. In that case, I use the single ablation using the microwave or either radiofrequency ablation. Take your time for real central core of the tumor is a very critical, very important, even if you have a strong weapon. And make the ablation margin and wait echogenic zone approaching the red line. In just 4 minutes, we can make quite satisfactory ablation margin. Actually, almost no wound. Pre-ablation MRI and post-ablation CT. Quite nice ablation considering tissue contraction by microwave. Second case is an inconspicuous tumor, very important. Because the tumor is inconspicuous on ultrasound, I choose 2 RF electrode. Actually, this is my last case before my retirement in this February. 1.5 centimeter in segment A. Could you increase the volume? Or a little bit more? Okay, thank you. So I almost always use the fusion ultrasound for accurate placement. And then to improve sonic window as well as to prevent thermal injury, I frequently use artificial situs in the peritoneum. This is how I make artificial situs. Fluid is really always our friend on ultrasound. So you can see the artificial situs at periapatal space, and we can separate adjacent column. The tumor size is not so big, but the tumor conspicuity is not so good. That's why I choose multiple no-touch radiofrequency ablation like this. Third needle approaching, just peripheral margin of the tumor. And then before starting the ablation, we need to add final registration. This is very important. And then make our goal of the ablation zone, including at least 5 mm ablation zone surrounding the yellow tumor margin. This is how I make sufficient ablating margin.
많이 불편한 말씀하세요. 네? 10분 정도 하면 됩니다.
This is the concept of no-touch ablation using the RF electrode. Okay, after the ablation, we can make quite enough ablation zone encompassing the index tumor. We need only 2 bandage. Really, I would say minimally invasive, isn't it? Pre-ablation and post-ablation, like wedge resection, I think. Okay, what is the current status of ablation? I would say fusion, CUS, artificial situs are standard technique in ultrasound guided liver ablation. But we should remember tailor-made approach is necessary depending on tumor aggressiveness, such as microvascular invasion or LLM tumor. So depending on the tumor aggressiveness, we have to take the smart strategy For smaller, well-defined negative microvascular invasion, we can easily cook with a single or two electrode. But larger and positive MVI, at that time, we have to consider more stronger weapon, even combined treatment. Moving to the future, what will be our future? Actually, this is not so easy for me. But this is what I expected. First, selection by defined indication, using the AI technology, and also development of accurate and optimal ablation software. And also we have to compete with other local regional treatment, including TARE or PVT. And in addition, we have to find the best indication for immune therapy plus ablation, precise ablation, new energy, and immunoablation. This will be our future. At planning phase, we can use many AI technology to predict outcome after ablation. And for accurate assessment of after ablation, ablative margin assessment software will be appeared, so we have to evaluate it and prove the real benefit. And also for performing ablation, we can use the augmented reality guidance for accurate placement of the electrode. Already in the market, there are a couple of AI-based software technology for accurate placement of applicator and a more objective assessment of ablative margin. There are so many software you can find in any conference, but unfortunately there is no software as a standardized as a fusion imaging or CUS. Furthermore, most software are based on CT guidance rather than ultrasound guidance. What about the new energy? For safe ablation, I would say cryoablation and ILD is the better energy source for the tumor with high-risk location. However, cryoablation still require much longer time, and ILD still very expensive. So I would say cryoablation should be faster, and ILD should be cheaper than nowadays. What about the histotripsy? Is one of the new kids on the blood and energy. There is no needle. It uses a pulsed ultrasound wave to induce bubble clouds from the gases naturally present in the target tissue. It can make creating the mechanical force strong enough to destroy tissue at cellular or subcellular level in non-invasive and non-thermal method. What about the immunotherapy? We are living in the era of immunotherapy. We already know ablation can induce the immune reaction. There are so many studies prove this concept. However, I think there are still a long way to go for real clinical application. And recently, adjuvant immunotherapy after local regional treatment, also many studies are ongoing. Recently, IM grade 50 announced clinical failure. There was no clear overall survival benefit after immunotherapy, after local regional treatment or surgical section. We have to wait. And also there are so many studies ongoing on local regional treatment plus immunotherapy, the mostly TACE or Y90, but we have to wait. This is what I expect our future. But as you know, we have so many new hope for our future. But please remember, our real future is a really small proportion of the current new. And also sometimes even expert can be wrong. Here is a good example. 15 years ago, one of my good friends who developed microwave ablation, he told me, oh, Professor Dr. Rhim, RFA has been already died because of microwave ablation 15 years ago. At that time, I remember, oh, really? But I don't think so. 15 years ago, his expectation. Another good example, remember 2016, AlphaGo appeared. In the same year, the godfather of AI, Jeffrey Hinton, gave this talk in one AI conference in Toronto, Canada. Could you speak up? Volume up, please.
So, let me start by just saying a few things that seem obvious. I think if you work as a radiologist, you're like the coyote that's already over the edge of the cliff, but hasn't yet looked down, so doesn't realise there's no ground underneath him. People should stop training radiologists now. It's just completely obvious within 5 years, deep learning is independent radiologists, so it's going to be a lot more experience. It might be 10 years, but we've got plenty of radiologists already. I said this is a hospital, and it did good out.
Yes, 10 years ago, his expectation, I think, would be wrong at this time. So even expert can be wrong. So we have to wait our true future. That means our current is more important than past or future. So I'd like to summarize my talk with this single slide. So I think it's time to dive into our box, not just expanding our territory, because there are so many jewels in our small box. Please think about deep ablation, like this. We already know, but from time to time we forgot. Thank you, Professor Jisan, Professor Kim Ji-won, and also all my mentors on ultrasound, Professor Cho, and Professor Dodd, and Professor Lim, and Professor Choi, and Professor Lim. Thank you for my root. Thank you.
I'd like to say a nice word to Jisan.